everyone. Thank you for being here with us today. Welcome to the Using Technology to Increase Access to Pain Management webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to CIRPD. As I mentioned, my name is Tanya, and I'll be moderating the webinar and handling the Q&A session. Our presenter today is Dr. Blake Deere. Dr. Deere is a National Health and Medical Research Council Australian Public Health Fellow and a co-director of the eCentre Clinic. The eCentre Clinic is a not-for-profit specialist research unit that develops and evaluates innovative internet-delivered treatment programs which aim to improve access to evidence-based psychological treatments for a range of common mental health and chronic physical health conditions. So I will hand it over to you, Blake.
Excellent. Good morning, everyone from Australia. I'm aware it's afternoon for most people participating, but I feel I should say good morning from Australia. I'd really like to thank Tanya and the Institute for inviting me to participate in this webinar series and talk a little bit about our work here in Australia, developing and evaluating an online pain management program, which we call the Pain Course. There are lots of different ways that technology can be used to help people who are living with chronic pain, and also health professionals that are trying to support people living with chronic pain. But what I am going to do today is really focus in on how technology could be used to increase access to pain management programs specifically. And I'm going to talk a little bit about a program that we've been developing and then share some results and walk through some results that we've been getting from running this program over the last couple of years. And hopefully that will be of interest, and I'm going to share some results that aren't even published yet, and hopefully that will be exciting. Fantastic. Just so that you know where we'll be going through this webinar, I'll start with a little bit of an introduction about the team and who's doing the research. I'll provide a little bit of background to why we would be interested in using technology and trying to increase access. I'll talk to you and let you know a little bit about the Pain Course, which is the program we've been developing here. I'll walk through the results of some trials that we've been doing and what we've been finding. Look a little bit at who seems to be benefiting, or whether we can predict who's going to benefit from these programs, which is quite an important issue, and then do a bit of a summary, and there will be time at the end for, I think we'll aim for about 15 minutes or so for questions and discussion at the end. Fantastic. In terms of disclosures, I think it's really important to go through this at the outset. My team and I receive absolutely no royalties from any of the work we do. We do receive a lot of non-financial support from different groups in Australia, like Chronic Pain Australia, the New South Wales ACI, Pain Australia, a whole heap, and we really appreciate the support. And we do get funding from different places, but it all goes straight into the development and evaluation of the programs we create. So the team, and I think it's really important to show you the team and tell you a little bit about the team because they are who does all the work. It's not me. The eCentre Clinic, as Tanya mentioned, is a not-for-profit clinical research unit and initiative of Macquarie University here in Australia. And its goal is really to develop and evaluate innovative psychological treatments for people with common mental health and chronic physical health conditions. The goal, or the core aim of the clinic, is really to increase access to effective, safe, acceptable and cost-effective evidence-based programs that are psychologically based. And we're not just trying to increase them for consumers or people in the community, but also for health professionals, trying to make them available to help them in their work with people they're working with. To date, we've conducted more than 50 clinical trials with more than 5,000 Australians across the country, and Australia is a very large country. And we've created 15 different treatment programs. We've started a lot in the mental health space, treating and supporting people with different anxiety disorders and depressive disorders across the age span. But more recently, we're moving strongly into looking at whether we can support and help people with different chronic physical health conditions like chronic pain. About 3.5 years ago, we were awarded a large grant from the Australian federal government to establish an online mental health service called the MindSpot Clinic, which you would be free to look into. It's directed by Professor Nick Titov, who co-directs the eCentre Clinic with me. And it offers a lot of the programs we've created for anxiety and depression for free to Australians online. And the goal for us at some point is to do something similar with the pain course and our other programs to make them nationally available. This is the team. We have a lot of different professionals in our team, a lot of psychologists and psychiatrists and research fellows, and we've had many clinicians and researchers come through the clinic over the years. This is just our website, in case people are interested, and you can kind of think about this as our front door to our research unit or clinic. So, to provide some background, why is there a need to innovate and to increase access to pain management programs? I have to apologise. I am going to focus on Australia, and it's just because it's the context that I know and it's the data that I know. But I know from a lot of my colleagues and friends throughout the US and Canada and Europe that there seem to be similar kinds of issues. Although there's different issues, there's a lot of similarities between Australia and all the countries. So hopefully it will make sense and be helpful. A lot of this will also be very familiar to everyone listening in. So we know that chronic pain is a very common and heterogeneous condition. It can occur after an injury, after surgery, it can occur as a result of numerous different diseases, and it can occur across the lifespan, and it can occur for no clear reason at all sometimes. In Australia, we know that it affects around 1 in 5 Australian adults. We know that it becomes more prevalent with age, so I think over the age of 65 it's around 1 in 3 adults experience it. We know that around 1 in 3 people with chronic pain experience marked disability. That is, it has a very significant impact on their life and what they're able to do day to day. And we know, depending on where you look, at least 1 in 2 people meet criteria for a clinical anxiety or depression each year for very understandable reasons. I think one of the interesting things to reflect on is we can look at these numbers like 1 in 5 and 1 in 3, but when you actually extrapolate those out and think about the raw numbers, it's almost overwhelming. So in Australia, I think we've got a population of around 23 million, and what this means is we've got almost 5 million Australian adults out there struggling or experiencing chronic pain, and 1.5 million who are experiencing a disabling level of chronic pain, and we've got 750,000 who have poor mental health in any given year. So it's a huge issue. We know there's now a broad agreement around I believe, around the optimal treatment for chronic pain, and of course really thorough, good medical investigation, examination and assessment and management is essential, and treatment if possible. But we also now know that pain management programs can play a very significant role in helping people to learn about their pain and manage their pain. To the point where there's enough evidence now that if possible, everyone who wants to should be able to participate in one of these programs. Of course, they all differ, but I guess the overall goal of pain management programs is to provide people with really good information about chronic pain, what we know about it, what's going on, and to teach people practical, proven skills to manage its impact on them, to manage the pain, manage its impact on their day-to-day lives. We know that pain management programs are typically and historically have been presented face-to-face, and in Australia they're usually provided within specialist pain management clinics. And we know that they take a lot of clinician time per person. In a lot of cases more than 6 hours per person. We actually have in Australia, it's very interesting, there's been a big move to focus on chronic pain and get a very good understanding of it and what services are available and how we can best support people. And there was recently a big and very good review of Australian pain clinics, and across the country 68 different pain clinics were identified. The research team, Hogg and his team, went through and really looked at what they were providing and what the nature of the clinic was. And we found that, it was found that 39 pain clinics were offering some form of pain management program. So not all clinics were. A lot of them were just providing good assessment and information and suggestions around management back to primary care providers. We know that the wait days for an assessment in those clinics was more than 150, which is interesting given that all the research saying that the longer people wait to get a good assessment and to get support, the worse their outcome often is. We found that, or it was found that more than 80% of the clinics were urban, so they were in major urban centres and cities, and which is a big issue in Australia given our landmass. And it was found that there was capacity for around 3,500 Australians to participate in a pain management program per year. When you think about all the people with severe disabling pain, that's only a drop in the bucket, a drop in the ocean of all the people who could potentially benefit. And so from this we know that very few people are actually accessing pain management programs that could help, which is really unfortunate. In terms of the rationale for internet delivery of pain management, there's quite a few different reasons why we might look at delivering these programs via the internet. One is that the tertiary centre model, at least which we use in Australia, where people are referred by their primary physician into a pain clinic within a hospital, that model is unlikely ever to meet demand. It's unlikely we'll ever get enough money to set up or establish those clinics to the point where they could support everyone. But at the same time, not everyone needs that high level, that high intensity of service. Not everyone needs to go into a specialist program and a specialist clinic. But I guess all the evidence out there suggests that people do need and benefit from the same information and the same skills that are often covered very well within those programs. There is significant proof of concept for internet delivery of these kind of programs in the mental health area, which I think has given a lot of support to researchers and teams around the world who are looking at the internet delivery of pain management programs. For example, there's more than 150 clinical trials now of internet delivered treatments for different anxiety and depressive disorders, which essentially are providing information about those conditions and teaching people again skills for managing them. A lot of the research is suggesting that the outcomes of those internet delivered programs are comparable to face-to-face treatments. They seem to be very cost effective compared with standard care, often because they seem to be requiring a lot less time than standard care, because a lot of the information and skills are actually taught via the programs, and so clinicians who are involved their role is more one of support and tailoring rather than teaching everything. And there is now good evidence that these programs in the mental health space are increasing access to treatment. Now, one of the big things or big questions is, well, what do internet-delivered programs, how do they differ, and what do they look like compared to face-to-face? And of course, there's huge differences between programs, but the one thing I would say is that they are essentially the same as face-to-face in that they provide the same information and they teach the same skills. They're all just designed to try and use technology to do that in a really efficient and accessible and safe way. There has been quite a bit of, there is quite a bit of emerging support for the internet-delivered pain management programs, and I'll provide some references in a second that if people are interested, you can go away and read a little bit more about this area. Most of the programs to date have been CBT-based, so based on cognitive behaviour therapy principles, but some are acceptance-based. And across the programs, there's evidence of improvements in average pain levels, disability levels, anxiety levels, and depression levels. I would say, though, that there are some important issues which people who are tuning into the webinar are probably already aware of. These are just from my perspective, but I think they're important to bear in mind. One is that there is no one type of internet-delivered intervention, and to date that's certainly true in the pain management space. They all differ a lot in the content, what they're covering, the structure that they use, whether they have a structure to them, and their format. They differ a lot on whether have therapist involvement and support or whether they're entirely self-guided. They differ a lot on how interactive and how much audio-visual material they have versus being more basic. And so there is no one type of program. I think that's important to bear in mind. Another thing looking across the literature is that the outcomes have actually been very variable across studies. So some will see improvements in one area but not others, and some other studies will find the exact opposite. And the level of changes that are being observed are also differing. And I think one of the real challenges in this space at the moment, because it is so new, is that there is little replication of studies. There are often low response rates at when people are followed up, and there are in some cases very high dropout levels. And these are really important things to bear in mind, I think, when we're looking at these studies. And thinking about the potential of internet delivery of pain management programs. These things all combined, and I think it's fair to say at the moment that while there is promising evidence, we're not sure of what components and what exactly is essential for these programs to be most helpful. We're not exactly sure who benefits, and because of these two things, I think we have to be cautious and are not sure where these programs can and might fit in to the overall system of trying to support people with pain. But they are promising, and I'll talk a bit more about that now. So here are, as Tonya said, I think this presentation will be loaded onto the website. Here are just some more references for people who are interested to go out and find a bit more out about internet delivery of pain management programs. I think these are a really good starting place. What I'm going to do now is really dive into some of the results we've been finding in our particular program, the pain course. So the pain course. An internet-delivered pain management program. So what is it? What does it comprise? The pain course that we've been developing over the past 4 or so years is still a CBT-based, cognitive behaviour therapy-based program. It comprises 5 core lessons, which are released systematically over 8 weeks. The core lessons cover the primary information, background information about what chronic pain is, what's going on, ways of understanding it, and then teaching skills for managing pain and its impacts. There's lots of additional resources in the course covering things like working with health professionals, different treatments, managing attention. there's lots of, and we think this is quite important based on all the feedback we've got, there's lots of detailed case stories and examples woven throughout the entire program. And these case stories and examples really share other people's experience and show what others have found helpful in terms of managing their pain and the skills, how they've used the skills, but also some of the traps with trying to manage pain. There's lots of automated emails that really help to guide people through and support people through the program. And then in most cases, we're providing the programs with brief weekly contact with a clinician who will get in touch each week briefly for about 10 to 15 minutes via email or telephone, just to support people through the program and answer questions and get feedback. You can think about the pain course as essentially any kind of online course that you might participate in. It's designed to provide the same information and skills as face-to-face pain management programs. And I guess the difference between it and say a self-help book or a self-management book is that it tries to provide a really clear structure and approach for working through the materials and practicing the skills, which often isn't present in some of the self-help manuals out there. Yeah. This is, our interface changes a lot over time and it's evolved since this, but this is essentially what it looks like when someone logs into the pain course. And you can see it looks like any kind of online learning environment. All of this wouldn't present at once. That would be quite overwhelming. It evolves or emerges over time as people work through. But you can see on the side you've got your lessons and your do-it-yourself guides and your case stories. You've got additional resources. You've got somewhere to communicate with your clinician and vice versa, and a clear timeline for how we work through the program. Here it's very hard to kind of describe and show what these programs look like, but here I've just grabbed out some slides from the core lessons, which provide the main information. It's been updated a lot since this, but it provides you with a bit of a sense of what it looks like, and you can see there's lots of kind of introductions and stepping people through. We've got detailed case stories who are talking about their experiences, but it's a very basic kind of presentation format, and we found that important because a lot of people don't have the systems or the internet connections to have anything or use anything more advanced at this point. I'm now going to step through some of the results of the different programs. I will step through these relatively quickly, but you can read more about them via these publications. And if anyone's interested, I'm happy to email those to you if you emailed me. So to date, we've conducted or are conducting 3 RCTs and 3 open trials. We've now got, I think, more than 800 Australians across the country who've participated in these trials. And I thought I'd step through them just to provide a good sense of what we're finding and how people are engaging with it. We started with just a basic kind of proof of concept randomized control trial where we really wanted to see whether this approach was going to be helpful and how people would find it and get feedback to improve the program as well. So what we did was we randomized people to receive the program immediately or to what we call a treatment as usual control group where they receive the program 8 weeks later. And in this during the program we would contact people each week for 10 to 15 minutes just to be helpful and support people through. In terms of demographics that we are finding, so we are finding a larger proportion of females at the moment are participating in the programs. The age is around 50 years with a big standard deviation of 13 years. So it's not a young group going through, it's a representative group. Around 30% are registered as disabled in Australia. And around 20% have less than 12 years of education, which is a low level of education relatively low in Australia. In this original trial, people needed to have had pain for more than 6 months. They needed to be over 18 years of age. They needed to be under the medical management of a medical professional, a GP or a specialist, and they couldn't have very severe depression. We include people with mixed pain conditions, which I think is a real strength. We have people with pain as typical kinds of pain like low back pain, fibromyalgia, and pain from lots of different injuries and diseases, including cancer and a whole heap going through. You can see that the average pain duration was around 7 years and the average pain intensity was around 6. And what did we find? So what I'll do is I'll step you through this here, and then I'll use this format throughout the rest of the trials. So we used conservative approaches when analysing the outcomes, and this is a measure of RMDQ is a very standardised measure of disability in Australia. And what we found was a 25% improvement in disability immediately after the course, and no change in the control. And then, as we often found in the treatment group, it continued to improve to 3-month follow-up. This is a common way that we summarise a clinical effect. It's called an effect size, and you can see it's around 0.88. And here I've just put the benchmark for you. It's a very crude comparison, but this is the average effect on disability that's been seen in the most recent Cochrane review of pain management programs for chronic pain. It's a very crude comparison, but I put it in here just to show that we are getting effects that are good compared to the benchmark. When we look at average pain levels, we see an improvement of around 18% in the treatment group and around 28% at 3 months, and the effect size again is good compared to the benchmark. Depression, we've seen improvement around 35% and 41% at 3-month follow-up, and again it compares well. We don't see much change in the control group, and it improves well compared to the benchmark. And we see similar improvement in anxiety, and it compares well to the benchmark. In terms of what we were finding, and this was one of the things I said earlier on was really important, was retention and acceptability. How acceptable are people finding it? And what we found in this small proof of concept trial, and it is a small proof of concept trial, was 93% completed all the lessons within the 8 weeks, which was incredibly surprising for us. We got a very high level of response from people, so more than 90% provided us with data and feedback around the program at the end of the course. And more than 90% were saying it was worth their time and they'd recommend it to others with chronic pain. And you can see on average we spent around 81 minutes per person across the entire course supporting them through the course, with a big standard deviation. But that's a very encouraging results and a relatively small amount of time, which is very encouraging. What we then wanted to do was, we've done is we wanted to replicate that. That's a very small, what I've just described as a very small feasibility randomized control trial, and what we wanted to see was whether we could replicate that in a much larger trial with more people and really look at whether what level of support people needed. So we randomized people to either get regular contact each week during the program, the option of contact, and this is really a person-centered approach where people could contact us and let us know if they needed to hear from us, but we wouldn't try and contact them each week. An entirely self-guided approach where we didn't contact people during the course and they couldn't really contact us unless it was an emergency, and then a control group. And we randomized people to each of these groups, and we're now completing the 24-month follow-up with everyone. And our goal, as I said here, was really to see, could we find the same outcomes, the promising outcomes that we saw in the first trial with a larger group of people, and really start to look at, well, how much support do people really need to work through these programs, because this speaks to how we might be able to use them in the future. One of the things I would say is that each step in this process we get an awful lot of feedback from people, which we use each time we run the program to improve it further, and we've rewritten the program now several times, significantly based on the feedback we get. Again, you can see the same kind of pattern in terms of who's coming into the program. You can see that there's a very high level of medication usage for pain and for mental health. More than 42% were on 3 or more medications for either pain or their mental health. The average pain duration was around 10 years. Average number of pain sites was around 3. And around 50% of our participants actually reported previously having participated in a pain clinic. And again, I'm just going to use these same results again, or this same format again to show you. So this is disability, and here we've got the percentage improvement at post-treatment. And you can see that roughly immediately post-treatment, it's around 20%, and then at 3-month follow-up, it's around 30%. Here again, you've got the effect size that we see, and then comparing to the benchmark. So this is broadly consistent with what we saw in the first trial, which is really encouraging and surprising for us. If we look at average pain, you can see that the improvement in pain is less than we saw in the first trial, but probably around 15% improvement, and it compares well to the benchmark. Depression, again, we're seeing very good improvements in levels of depression and low mood, around 35% improvement, a very good effect size, and that compares well with the benchmark. And anxiety, the same kind of thing again, which is comparing well. And one of the things I think you can see across all of this is that the control groups actually aren't improving much at all over this 5-month period. In terms of retention and acceptability, again, which is really important, we did find in the self-guided program that immediately after the course, less people had completed at 72%. However, one of the interesting things we're finding, which is actually very encouraging, is people are continuing to access and log into the course well after it finishes, and so the completion rate often by around 10 to 15% afterwards. You can see that we are still getting very high response rates to our questionnaires and high levels of feedback at more than 85% or 84% immediately post-treatment, and we're getting high levels at 3-month follow-up. Again, more than 90% are saying it's worth their time and they'd recommend it to others with pain, which is really encouraging. Here, though, you can see across the different ways we supported people through. In the regular contact group, we spent around 67 minutes per person. In the optional contact group, around 12 minutes. And in the self-guided group, around 5 minutes. And this was really around managing mental health and pain crises as people worked through. This is incredibly encouraging because you can see how this would have implications for how we might offer the course. If it really only takes 12 minutes for similar kinds of outcomes across the groups, then this may be a model that would really work. And that is a person-centered model where we're monitoring them and they're letting us know if they need support throughout. The next trial for us was really to run through and look at whether we could deliver the program not just via the internet but also via a hard copy workbook. A lot of people in Australia still don't have access to good internet and or technology, and so if we're really trying to increase access to pain management, we need to look at different methods of doing that. And so we were really interested in how an internet version versus a hard copy workbook version would do and follow people up. So we randomized 168 people to either get the internet delivered version of the pain course or a hard copy workbook version of the pain course, and we're now just completing the 12-month follow-up of everyone. And I'm aware there's a very long history of workbook delivered or workbook type delivery of pain management programs. This is a copy of the pain course printed out into a workbook. You can see we're a research unit. It looks like a research manual, and on the right hand side there I've put the manual. It doesn't really work in the international context, but next to an Australian 50-cent piece, which is probably about an inch in diameter. And so you can see it's quite a hefty book that we've worked through with people. I have to apologise, I don't have any specific data around the nature and characteristics of people going through this course at the moment, because we're still really just collecting the data or working through the data, but I can say they look very similar to the groups that I've previously shown you. And the other thing I'd say is these results are very tentative and raw data and very raw, but I thought I'd share them anyway because I think it's quite encouraging. Again, you can see we're getting quite similar outcomes for the internet and workbook groups in disability, maybe even favouring the workbook group a little bit, but it compares to the benchmark quite favourably. In pain, we did see a very big change in the workbook group, but we'll have to look at that in more depth. But you can see again, it's generally good improvements in average pain levels compared to the benchmark. Depression, we're seeing again similar outcomes in depression, which are maintained, and they're good compared to the benchmark. And anxiety, the same thing again. So very encouraging results, and you can see that we're kind of finding the same patterns of results across all of the trials, which is really encouraging to us. Again, in terms of acceptability and retention, 75% completed all the main lessons by the end of the course. We got a lot of data back from people, and again, more than 90% are saying it's worth their time and they'd recommend it to others. And again, we're seeing, it's taking roughly 70 minutes with regular clinician contact to support people through the course. I'll start to wrap up soon. I just really want to share this data with everyone, which is hot off the press, and it's really one of the things we're really interested in is, can we predict who will benefit from these programs, which is going to be really important because we don't want people to be spending their time on an internet delivered program if a face-to-face program or some other program is actually more essential and is actually what they need at this point in time. And so it's really important that we do spend time looking at and understanding who may benefit and who won't, and how we might triage people to different services or different options. And so what we've done recently, or what we're starting to do, is look at whether we can predict who will benefit from these kinds of programs. What we've done here, what I will show you here, is a whole series of stepwise logistic regressions, and I have to say I'm not a statistician, but essentially what these attempt to do is identify unique predictors, characteristics of people who are more or less likely to improve. And we've focused on a whole heap of demographic, initial severity, clinical and treatment kind of variables that are available to most people or to most services as people enter these kind of programs. And what we're trying to do is look at whether we can predict who will make a 30% improvement in each of these outcome areas. And a 30% improvement, it's not perfect by any means, but it's been identified as an important clinically meaningful amount of change. So there's a lot that's just come up on your screen, and I won't talk through it, but you can see the kind of variables we've looked at. Here we're trying to look at whether we can predict whether someone will benefit by 30% or more in their disability level. And we've put in into the models a whole heap of demographic variables: age, gender, relationship status, employment status, a whole heap of clinical variables: pain duration, number of pain sites, medications for pain, medications for mental health, compensation, Their initial severity levels on a whole heap of variables, initial disability, pain levels, pain self-efficacy, fear of pain, pain acceptance, and then a whole heap of variables around their treatment engagement, the level of support they got in terms of clinician time, whether they completed the program, and the number of the logins. And what you can see here is that there are a number of things that are coming up that are predicting whether people would improve or not. But there's no real consistent pattern, and I'll talk a bit more about this later, but there's no real consistent pattern here that would allow us, or that really predicts. This is average pain, and you can see that it's all kind of changed again in terms of the variables that may be important. Depression, it's all changed again on your screen, and then anxiety, and it's all kind of changed again. And just to summarize that, and I'm not a statistician, I find those kind of tables overwhelming. When we look at, with all those variables I mentioned, and we look at whether we can predict who will benefit in terms of disability, average pain, depression, and anxiety, these percentages here are the accuracy with which we can, or the amount of variance we can explain in whether someone improves, and it's really low. It's not meaningfully above chance. And what we're finding is that, at least initially, there's very few dominant or consistent predictors of clinical outcomes. So initial severity levels and type of pain and how long people have had pain don't seem to be related to whether or not they'll improve. There are some important things in there influencing outcomes in each domain, which will be important for future research, but we can't predict yet who will improve, which is important to bear in mind when we're thinking through how we might use these programs. So where to from here? Just a very quick summary, and hopefully I haven't put anyone to sleep. But we are finding internet-delivered pain management programs are clinically effective. They're likely to be cost-effective given the relatively small amount of clinician time required, particularly for some of the models we're starting to play around with. They are very acceptable, and they do have a significant potential to increase access to pain management programs. But I would be one of the first to say they're not a panacea. And so we need to be balance that kind of hopeful optimism and investment in this emerging kind of area, but at the same time be realistic about it as well, and not neglect other important initiatives and issues in the space. There are lots of important outstanding questions, and hopefully that's come out from this presentation, and it's really who do they work for and when, and a lot more work really needs to focus on this before these programs are rolled out as kind of routine programs and routine options for people, in my opinion. We don't know what makes them these programs optimally effective. There is lots of variation in programs in the level of outcomes seen, and that's important. There are lots of questions about whether we can implement these programs into routine care, and of course how they would fit in and where they would fit in. And it's a very early area, and lots of work still needs to be done. I put this in here just to bear in mind. I don't know whether people are, it's a good reminder for me, but I don't know whether people are familiar with it, but it's the Gartner hype cycle chart, and it just maps a whole heap of technologies across a whole range of domains and kind of where they fit. And it's just a reminder that often we have inflated expectations about how new technologies, how helpful they will be, and it's very easy to get caught up in that. They are usually helpful and they are usually productive, but we have to be realistic with them, and there's a lot of issues to work out along the way whenever a new technology comes out, and I think these charts help to remind us of that. That's great. Thank you very much for listening.
All right, wonderful. Thank you very much for that, Blake. That was a really good presentation.
Not a problem.
Let's see. So a couple of questions. One, someone was asking what explains, or if you know what explains, the low rate of uptake by men and how this might be addressed in future programs.
Yeah, that's a really good and important question. I think I'll answer it two ways. One is that the encouraging thing is that we are finding that men are on average do benefit in the same way as women. So it's not an issue of benefit. What I wonder, and we don't have specific data about it, is that in Australia we have a general issue, and I don't know how generalised it is, but we have an issue in Australia where men are far less likely to seek help for a whole range of health issues, and particularly this kind of help, which is kind of self-management psychological help. So I wonder whether it is part of that general trend. So it's not specific to our program, it's that this group, men, are harder to engage and get into these kind of programs. And so moving forward, I wonder whether the approach would be, if you were to roll these programs out, just more targeted campaigns to try and get men into these programs.
All right, and then someone was asking, how does this compare with treatments using acupuncture? And I think we could even broaden that out to, do you know how the online self-management compares with other treatment types?
I can't really comment with any authority on the other different medical treatments, just because it's not a literature I know really well. But I guess, as I was kind of showing in there, it is comparing very well with world kind of standard face-to-face pain management programs. So the outcomes are consistent with that, and I believe there is evidence out there that face-to-face pain management programs lead to further improvements above and beyond standard kind of medical and allied health interventions.
All right, and then is there a specific type of chronic pain that your sample groups are selected from? Back pain, post-surgery, arthritis, etc.?
It's a really good question. One of the things we've tried to do from early on, because our goal is to really increase access, is to open it up to a very broad group of people with chronic pain. So there are no limitations in terms of what conditions, pain conditions people can have. And that was a deliberate decision, and has really helped us, in fact, because as we've gone through, people have known they may have had quite a rare pain condition, for example, and have known that the course wouldn't be tailored for them, but there would still be helpful things in there, but they've provided us with feedback that then has helped us to improve it further for people with similar conditions to them. So there is no specific group we're targeting, and the groups are very, very heterogeneous. As I said, we've had people with terminal cancer pain, spinal cord injuries, paraplegia, quadriplegia, all types of neuropathic pain conditions, back pain, osteoarthritis, rheumatoid arthritis, so lots of different conditions. One of the next big steps for us as we get larger samples is actually to start to report the results of the program for specific groups, and suspect that we'll hope that will be helpful for clinicians and people out there managing different conditions, so they can get a sense of how helpful it will or won't be for them. But we need really large samples to do that fairly and accurately.
Right, very good. Let's see. Someone asked, and I think this could be, I'm going to change the question just a little bit, and the person can let me know if it's not quite what they were aiming for. But did you get any feedback from people, since it is largely people with chronic pain, who had difficulties because of sitting for a long period, or like neck pain, or issues around taking the course due to their pain and being able to follow through with it due to their pain issues?
Definitely. Yeah, definitely. Both because of their pain condition, and also for a lot of people because of the medications they're on. I'm not a physician, but a lot of people really struggle with memory and concentration as a result of their medications and pain. And then, of course, all the issues around sitting or working through an online program in a while seated, for example, at a desk. One of the things I would say though is we've been really encouraged by the approach people have taken. So they've often told us that, and so all of the and have figured out clever ways that they could work through the course. For example, a lot of people, and you can print out all the materials, and a lot of people are printing them out and working in them in an offline format. So while we say internet delivered, for some people it is almost a workbook type intervention. But people are also being quite creative and for example, using laptops and tablets, which I think is really revolutionising things because people can move around a lot while still accessing the course. Yeah, and I think one of the other benefits is people can, in this format, can come back to it repeatedly, and we often encourage people, based on all the feedback we've got, to spend small chunks of time on the course, 10 to 15 minutes, rather than large chunks, which most people can't manage for a whole variety of reasons.
Very good. Someone asks, how do you feel David Butler and Laura Marr Mosley's Explain Pain and the Protector Meter stack up as tools from the Australian pain education landscape, and wondering if they influenced your program at all?
They're fantastic tools and great books. I haven't used them myself, and but they were an encouraging motivation for what we're doing here, because we're very much covering similar things, but then expanding on it as well in terms of teaching actual skills that people can use. But there's also a big history, as I said early on, in the mental health space, and chronic pain isn't a mental health condition, of course, but there is a lot of evidence in the mental health space of running these kind of programs and running these kind of programs and their effectiveness and acceptability. So, and that's partly where my background is, so I've drawn a lot from that as well.
All right, and then someone asks, are you looking to open the study and the pain course to individuals residing in other countries?
Definitely, yes. We definitely are. We get a lot of interest, understandably, from people all over the world who want to participate, and we're hoping to, towards the end of this year, hopefully, start to offer the pain course internationally to people. Of course, in that format, we'd probably only be able to offer it in the self-guided format, but then most people will probably, we hope, be working through with their clinicians in their home countries. And we're also starting to look for and work with collaborators. We have a collaborator in Canada who's now starting to test the pain course there, and that's very exciting for us. Essentially trying to look at whether it's as helpful Canadians with chronic pain and whether they can use it and how it would work over there. And I guess there's a lot of work in this space because there's so much demand. And really, it's not worthwhile, I don't think, everyone trying to recreate these kind of programs because so much effort goes into them. But there's, it's good for people to direct their effort at thinking through how they could use it. Yeah.
Very good. And is there anywhere on your site that people could sign up for alerts as to when you might be opening that up in case they wanted to participate?
Definitely, yeah. So people can register their interest via our website in the course. What we then do is, as soon as we're about to offer it, we send emails out to everyone letting them know, and then they can get in touch with us with any questions or start to fill out a very kind of basic application just for us to make sure it's going to be suitable and okay. At the moment, we aren't able to offer clinicians access to the program, and that's just because of the ethical approvals we have at the moment, but that is certainly a goal in the future as well.
Okay, wonderful. And someone wondering if you had any feedback or anyone this person's wondering if these online tools are being utilized more by patients would a computer be able to be considered as a medical support tool for insurance purpose? Like, do you think there would be an argument for that in the future?
Ooh. Um, I'm going to be very cautious around that because I'm not at all familiar with the. I'm guessing that might be a North American question, and the health systems in Australia and North America are very different. I could be wrong, or could be Canada, but it's very different. I'd be cautious about answering that.
Okay. Yeah, that's kind of what I thought. I think that would probably be something that you would need to speak with your insurance provider about. And it would probably entail providing evidence of how you're using your computer, etc. But I would agree we have to execute some caution on discussing that. But I think it's something you could definitely explore, but with your insurance providers.
Yep. And these are the kinds of things that need to be worked out in different countries and by collaborators, and there's a lot to work out how these things fit into different health systems and settings.
Yes. And then we've gotten several requests for information about who the Canadian collaborator is. I was speaking with Blake earlier, and I'm going to go ahead and get in touch with her. And then depending on her response, I'll distribute information about that in the follow-up email to everyone. So I hope to get you that information, but I'll pursue that just so I can get more specifics about what she's doing and what she's willing to provide as information about that to everybody.
That's great. I could get into a lot of trouble.
Yeah. I think I'll check with her first, and then I'll distribute whatever it is that she wants to distribute about the project and what she's doing and how people can get involved.
That sounds great.
All right. And I think that's all our questions. Yes, thank you very much, Blake, for the presentation. Very interesting work that you're doing. I'm looking forward to following up on it and keeping an eye on where you're going and how things come along.
Thank you very much. Thank you for the opportunity and the invitation. I really appreciate it. And I really appreciate everyone's interest in what we're doing.
Wonderful.